Yes, sir, you're audible and visible.
Yeah, yeah, you are both. You are both visible and audible.
Thank you. So hi, I'm Vishwarup. I'm one of the consultant surgeons in heart lung transplant at the Artemis heart lung transplant unit. Um, so it's a relatively new unit in the northern part of the country. But the team that has kind of been associated with this transplant center is one of the foremost elite teams in the country. We're close to 710 solid organ transplants and LVADs in this country over the last 7 years, operating out of 6 centers. So the topic today is heart transplant for foreign nationals, what's in store, the socio-economic aspect and the legalities of it. So straight away coming to heart transplant in foreign nationals, heart transplant, unlike lung, is little forgiving. Then heart transplant, we have something LVAD, which is kind of a bridge to an heart transplant for those with end-stage heart failure. And this is often an answer because when foreign nationals do come to India, I'm not sure if you're aware of the, I'll just show you the slide. So just let me know if the slide is visible. I'm sharing. Yeah. So this is the structure. Is the slide visible now?
Yes, sir, it's visible.
Yeah. Okay.
Yes.
Yeah. So as you know, there's a three-tier system in the organ transplant in the country. There's the NOTO, which is the National Organ and Tissue Transplant Organization. Then there are about 5 ROTOs in the country, which are the 5 regional organ transplant organizations. So there's one in the north, one in the south, one in the east, one in the west, and one in the northeastern part of the country. India is almost a country with about 2,000 kilometers, 2,500 kilometers in width and about 3,000 kilometers in length. So it's quite a varied geographic area that needs to be covered in a short span of time of 4 to 6 hours for thoracic solid organs. And then there are multiple rotos in every state capital has got a roto. So for a foreign national to be listed, the listing comes through the noto. So he or she is listed into the noto, which is the national body. But he or she is eligible for an organ only when the organ has been refused by every single other hospital in the country for size, shape, blood group, or non-ABO mismatch. And it is only then it is routed to a foreign national. Truth be told, there has been a little bit of difficult press about it in the country initially, because initially it was not as initially it was more scientific because we were using organs for people that needed it the most. But now probably it goes to the foreign nationals at the end of going through every other checks and balances in the system, which takes about a good 6 to 7 hours at the least. So by this time, the viability of the organs are a challenge. Coming to the Kim's Artemis thing, I'll share this slide. Screens. Give me a second. So yeah, so this is the Kim's Artemis number. So this is a slightly older slide. We are about 660 transplants, then about 500 plus ECMO runs, 60 plus LVADs, the first breathing lung in the country, and the first team to use the sub normothermic or the hypothermic organ preservation in the 10-degree box and the ex vivo heart in the lung box. Coming to the next slide. So this is the scope of our services. We offer heart transplant, lung transplant, combined heart lung transplants, ECMO transfers, pan-India as of now. Ventricular assist devices, as well as ECMO as bridge to recovery for transplant, or bridge to recovery or bridge to decision for transplants. So at this point, I would really expect some questions coming in, because without it being interactive, it will be very difficult as to know what the audience wants to know. So if anybody has got a question, I'd be open to answering it.
Okay, Dr. Biswarup, normally the format that is followed is the specialist masterclass. They finish the presentation and they take most of them. They take questions in the end.
Okay.
But I request the audience to please keep asking your questions.
Yeah, you can put in the chat so I can keep
Right.
answering, because otherwise, I mean, I can talk on heart transplants and VADs, and that's fine. I'll do it that way. No worries.
Okay, Dr. Biswarup, my request would be that the objective is for our doctor partners to know
Yeah,
when is the trigger that there is a fit candidate, the
yeah,
complexity for the
no
heart
worries.
transplant, and if they can understand when they have to make a referral, what preparation are needed at their end,
Yeah,
and then generally how you go about doing it, the
yes.
challenges, the success rates,
No,
etc.
no worries. Sure. Give me a second. I had the presentation split in two halves. Give me a moment. I'm just doing the presentation now. So many windows I'm working on. Give me a moment. I'm just connecting the slide. Give me a moment. It's not opening. Give me 1 minute. screen visible now?
Yes, sir, it's visible.
Yeah, fine. Fine. So coming to LVADs or heart failure. So the primary therapy for heart failure is basically the initial part is medical management till they come to about anything less than a 20% ejection fraction. Once they reach that number of about 20% ejection fraction is when we kind of start thinking about different kinds of therapies or devices for heart failure. So initially, we think about putting them on what is called as an AICD, which is an intracardiac defibrillator. Later on, as their heart size keeps on increasing, they might become increasingly sick. They might increasingly become breathless, reach something known as an NYHA class 4 or an Intermax class 4/3. And it is then that these patients further either need to go on a veno-arterial ECMO support for some time for decision, or in case there is a straightforward indication that the right heart is reasonably well, we have done a right heart catheterization, or we have done a very good echo for the right heart, we can straightforward offer them what is a ventricular assist device. So ventricular assist device is basically a small pump which is implanted inside your body, controlled by a small battery, which is mostly worn by the patient throughout the day in his body, which is supported by 2 battery packs on either side, which normally have a 24-hour supply of power and needs to be constantly charged during the time while he's either asleep or he's resting or he's at home, so that he never runs out of power while he's on his LVAD. The only life restriction with an LVAD basically is that you cannot be involved in any swimming or other related activities that involves underwater activities. But apart from it, people have gone to gyms, people have run half marathons with LVADs. And today the size of the LVAD is very compact. The LVAD has become much smaller, and so it is a lot less restrictive than what a HeartMate 1 or probably a hardware initially used to be. So there are about 3 or 4 generations of VADs. We're currently in what is called as a 3+ generation. So the first generation VADs were basically the thoracic VADs, the HeartMate 1. The second generation are probably the HeartMate 2, the hardware. The third generation VADs were classically the magnetically levitated bigger pumps. And today we have reached the era where we are kind of using magnetically levitated, extremely small pumps with very low risk of thrombosis, which is the HeartMate 3, which is currently in the picture. And the HeartMate 3 is almost the size of your palm. If I have a real life picture to show you, I'll just try and fetch in a real life picture. But that's a patient picture, so I would anyways kind of have to avoid showing that because I have not sought permission from the patient. So, and in the HeartMate 3 ones are probably about the size of your palm, weighing about 94 grams without its housing. All in all, everything put together, it is less than 150 grams. The batteries are a lot lighter today with lithium-ion batteries, and they kind of, so they say they're 24-hour powered by the 2 cells, but there have been occasions when people have gone on holidays or people have gone camping and they have been out of power for out of the grid for almost 36 hours, and yet the LVADs have worked fine. So smaller VADs with longer lasting batteries has decreased the life limitation of patients wearing them, as well as has increased or increasingly been used as destination therapy. So coming to the use of LVADs in different types of therapies. So VADs can be used as a BTT, which is a bridge to transplant, where you've definitely accepted that this patient needs a transplant and you've worked him up, but he's in a difficult situation, like he's a foreign patient in India and he just can't get an organ. So you put him on a VAD with transplant being a definitive answer. Then there are bridge to candidacy. Which is basically for those patients who are so sick that you just want to save them that day, and you don't know whether he is going to make it alive in the next 24 hours. In the next 24 hours, and so you kind of put them on a VAD or a VA ECMO and take a decision whether you can replenish or whether you can improve the circulation to all his end organs and make him a suitable recipient or candidate in a few weeks or a few months. In personal experience, I would feel about 4 to 5 weeks on a VAD, you are so well nourished in terms of your end organ circulation that you more often than not become a recipient for a very good recipient for a receiving heart. The only thing is you become very sensitized in terms of multiple antigens being switched on by a foreign circulation in your body. But otherwise, your heart function, your liver function, your end organ function, like your kidney functions, your people with diabetes and all those that have small vessel angiopathy. So those people benefit a lot. So their chronic limb ischemias are gone, their kidney functions return to near normal, their liver enzymes are normal, and as is. So that is the bridge to candidacy. With third generation, whereas the other thing is they are increasingly used as bridge as destination therapies because the risk of thrombosis in these VADs are extremely low. I just call me for just a second. Do I have the permission to take a call from the hospital?
Yes, sir, please.
Hello?
Go ahead. Yes, sir, please.
I'll just take the call. I'll just call in a moment. Thanks. Bye. Yeah. Sorry about that. So they're increasingly being used as destination therapies. So destination therapy is somebody who's 50 or 55 plus, who has a reasonable expectation from life, who probably does not want to or is not a fit candidate for outrightly and heart transplant. So in those kind of patients, these VADs are now increasing their life. Earlier, VAD used to last a max out of somewhere between 3 to 5 years, but these destination therapy VADs are lasting somewhere close to 10 to 12 years, some even more. Because it is not uncommon these days to see patients with VADs implanted in the early 2010s, the 2012s and 13s, still alive and reasonably well. And then comes the temporary short-term device. Hi.
Dr. Biswarup, if I can interrupt you.
Yes.
Yeah, so we have two questions.
Yes.
One from Dr. Orona Paul. He practices in Nigeria.
Yeah.
So his question is very practical, that how are we sure, or the confidence level that the patients who are referred, they will get the right match, like the organ will be available when they get to India?
Okay. So see, there is no definite yes or no answer to it, but we can tell you this. So we are one of the largest transplant teams with presence in the north, with presence in the north, presence in the south, presence in the western part of the country. So this exposes us to 3 rotos directly, which are the active rotos in the country. The eastern or the northeastern roto is not the most active ones. And so if you are one of our patients in this KIMS Artemis team, so KIMS operates out of KIMS hospitals in Hyderabad, Artemis hospitals in Delhi, KD Hospital in Ahmedabad, Surgeon Reliance in Bombay, Esther Care and KIMS hospitals out of Bangalore. So we have a very good presence with a very good network. We are the only team in this country that does hypothermic oxygenated perfusion, which increases the longevity of the organ from a 4-hour static cold life to somewhere in the range of 8 to 10 hours. So if you are in our list, your chances of getting an organ at this point today is probably in this country is probably the highest and the quickest. How quick? I would not have a definite answer. That also depends on a lot of patient factors. Say you are an AB blood group, you are an average size individual in the 160 to 180 centimeter height range. You are in that typical Indian built of 70 to 90 kgs, because you can only accept a heart that is about 10% bigger or smaller to you in terms of the body surface area, or 10 centimeter higher or lower in terms of the height. So a lot of the foreign populations have a very different body habitus, and they occasionally, it is a challenge for us to provide them an organ, because more often than not, even once or twice if an organ comes to them, it is a huge size mismatch. Having said that, the longest wait period I've seen for foreign patients waiting for heart transplant especially is in the 12 to 14 month range. The few that we have handled, almost everybody barring maybe one that I can remember that came as a heart transplant patient and got converted to a VAD, and the other that could not find a heart and just went back. So barring those 2 patients, I do not think, and I'm talking about 20-25 patients in total that we have transplanted over the last 5 or 6 years that I can recollect in my memory. And otherwise, most of them have got a heart, not in time, but towards the end of it. One of them was put on what was the last thing, which is a temporary short-term device, a Centromag. He was in Centromag for about 6 weeks and he got a heart. So we had exhausted our options by then. So one of the primary challenges we as a transplant physician face is that these patients often are referred to us in a very poor state, in a state where even a VAD becomes a far-fetched reality. So timely referral and early coming to India, even if it is only for a workup and for nothing else, is probably the right way forward.
So, Dr. Biswarup, if I can understand you correctly, so it's a risk, right? Like anything. I mean, there's a chance that they may get the matching organ, or they may not. But
there is a small chance they may not get an organ. But majority of them, if I'm saying that I can only recollect 2 out of 25 people not getting an organ, which means 23 out of 25 got an organ.
And sir, how about the waiting periods? Like, what's the range? I mean,
the median waiting period will be about an hour.
Oh, okay. So it's that quick once they're here. If the organ is available.
For heart, the median waiting period is about an hour. It's about an hour. About a year. I'm so sorry. It's about a year. Not more. Not more.
So typically, then the family would have to stay and wait for the organ to be available, right?
So then comes the socio-economic aspect of the transplant, which is you need to stay in a different country, have very different food. A larger part of the northern and western India is vegetarian. A larger part of northern and western India is vegetarian. So you would have very different food choices.
No, sir, now they have apartments and people.
I mean, the situation today might be a lot better than what it was maybe 5 years back, when it all, or 5-6 years back when it all started.
So we have another question, and this is asked by Divya sir, that how many days for LVAD admission?
How many
days for LVAD admission?
So straightforward. For an LVAD workup, it is about a week when we can have a go at you, do a right heart care, do all your numbers, running through a transplant meeting or a VAD meeting or heart failure clinic, and we can straightforward tell you are a good candidate for a VAD. Truth be told, you look at anybody, you do them a battery of tests, you do a very good echocardiogram. You can more or less eyeball and tell that person if he or she is for a VAD. But yes, to adhere to the regulations, you need to do a right heart catheterization, you need to do a coronary angiogram, you need to do a CT scan of the chest to measure the size and everything, and size the VAD and determine the pocket size. And those are very fine technicalities. But on a gross scale, if you look at somebody, his numbers, basic blood batteries, and kind of his echocardiogram, you can make a choice more or less that, oh yes, this gentleman is a candidate for a VAD. Yeah, you can do that.
Okay, Dr. Ornana Paul, I hope your question has been answered, but if you can, like, there are so many complexities involved in a transplant where
coming to India in a reasonable state is the biggest challenge. I said I have seen maybe 2 out of 25 patients go back without a transplant. Most of them either have had a VAD or had a transplant or were put on temporary support therapies and then went on to have a transplant or a VAD. But if I get 25 referrals, I only see about 2 of them properly worked up, or 2 of them at a stage when you can discuss with them possibilities of a VAD or possibilities of a transplant. Most of them would be so in stage 5 to 10% ejection fraction. I mean, nobody reaches a 5% ejection fraction over a fortnight unless it is a viral myocarditis. So the
Dr. Ornana, any follow-up question? Like, it will be great if you can ask Dr. Biswarup directly without
follow-up question would be, because I've only seen my side of the story.
Yeah, because it will be better that if you ask directly instead of me being the messenger. Dr. Ornano?
Is there any other question anybody else wants to ask?
No, sir, we can go ahead. Questions will keep coming up. I'll
Okay.
keep getting them.
So no worries. So coming back to the VADs, so the long-term implantable VADs, there is again a decision to be taken. So if we are talking about long-term VADs, we are kind of broadly classifying them for adults and or children. And for adults, the answer today is in HeartMate 3. For children, there is a slightly better answer in something called as an Jarvik Heart or a Jarvik JV 2000. So which is a smaller pump, supports people about 1.5 meter square body surface area, which is typically an adolescent or a child that has a childhood or congenital cardiac deformity, which has caused an intractable heart failure. So that is the screen being shared? No, I've lost the screen share. Give me a second. Screen share again. I've lost the screen share. Give me 1 minute. Is my screen being shared? No.
It's visible now, sir.
It is visible now, but not the presentation that I want to show them. Yeah. Yeah. So this is basically, if in adults we're talking about in HeartMate or HeartMate 3, in pediatric population we're talking about a Jarvik JB 2000. A Jarvik is a lot affordable because a Jarvik is priced around the 25,000 American dollar, whereas a HeartMate 3 would be close to 100,000 American dollar device itself. Jarvik is trying to come up with a pump which is basically magnetically levitated pump, which is a third generation VAD pump. It is in the process of getting an FDA approval as you speak. They have applied for an FDA approval in early June of this year. We as a team have also collaborated with an Australian firm and the Indian Institute of Technology in Kanpur. One of our own LVADs is under human trials, which has only finished its second phase late last month between the launch of the KIMS Artemis program and today. And there was a very exciting discussion in our closed forum that the results are very encouraging. It might not be long. It might be as short as late 2026 when the device is at least up for a CE approval and later an FDA approval. So we would then be able to provide a VED therapy, an implantable long-term VED therapy at a fraction of a cost, less than half of what we are currently paying, with American manufacturing, 100% tax on it, and so on and so forth. So
Dr. Biswarup, in India, we ourselves, our citizens, there are a lot of awareness programs that a lot of people need organ and to increase the organ donation participation. And our law is very clear that when an organ is available, preference is given to the Indian citizen.
Absolutely.
In that case, that in our country we ourselves face shortage of organs.
So there is two way of looking at an organ for a foreign recipient that way. If you have a foreign recipient in your hospital, say it is in KIMS hospital or it is in Artemis hospital, say it is in Artemis hospital, Delhi or Gurgaon, and there is an organ that is being offered to the National Organ Transplant Organization by Artemis hospitals itself. So in that case, the moment the state organization or the SOTO refuses the organ, or anybody from that region is not able to come and procure the organ, it is a very archaic rule. But then because the patient is your patient, your in-hospital patient, the patient automatically becomes the top of the priority. You need not go to all the rotos and get their NOCs before you can offer the organ. You just need to go to Noto. You need to inform Noto that we are offering an organ from such and such a different patient. We have an in-hospital patient who is in foreign national. It has been refused by the state organ transplant organ authorities. which is the state body, which covers all the hospitals, maybe in the 100-150 kilometer radius. So then that foreign national automatically becomes a candidate to receive that organ. It is a very funny thing, but it works that way. If it is some other hospital, then it has to go through the NOTO, through every roto. Every roto has got to give you an NOC. And by the time people in Guwahati are awake, you lost that organ. That's the reality. That's the reality of it. But if it is your hospital, so yes, if we are admitting or we are taking in foreign patients, which KIMS does, so we promote a lot of in-hospital activity in our trauma units, in our neurology units, for encouraging people that are facing a end-of-life coma or a brain-dead situation, for grief counselors to pitch in, talk to their families, and make them understand that it is a very altruistic way of kind of bringing an end to your life. What better way than to continue living on? So this is a very social thing. Grief counselors and kind of intensive care nurses, intensive care specialists, they have a huge role to play in this.
Okay, so sir, while somebody who is a heart transplant candidate, they are anyway very complex. They're in a very complex situation, and waiting period may be as long as a year. So how they going to navigate that uncertainty, because any health challenge may occur. There might be mortality.
In heart, one of the answer is a temporary VAD or an VA ECMO. And if there is a deterioration in the health condition, reassess them for a VAD. Somebody on a VAD that wanted a transplant and did not get a transplant is almost unreal, because VAD will make you be able to wait for years together now.
Okay.
VAD 5 years back used to be a 5-year solution. VAD today is a decade-long solution.
Okay. And sir, how what is the not the stay and logistics part while they're waiting? How is the hospital treatment financial implication on the patient waiting for transplant?
Okay. So once they are staying in the country as a heart failure patient, so they would probably be requiring to visit the hospital once every fortnight. And their monthly expenses, I would deem hospital expenses and medication expenses, I would deem to be in the range of $1,000-$1,500.
Okay.
If not more. And so for 12-14 months, if you put all of it together, we are probably looking at and the $20,000 of peri-transplant or pre-transplant medications and numbers for people that are heart failure patients waiting for a heart transplant in this country, foreign nationals.
And sir, how much does the heart transplant surgery, financial implication of the heart transplant surgery itself?
So the heart transplant surgery for a foreign national with all the legalities and everything would be in the range of $50,000.
Okay. Oh, that is a fraction of.
South of $50,000, a little less than $50,000 actually. I think the package that Artemis offered is $45,000 for a transplant and $5,500 for a workup.
So there's a question from Dr. Dinal. Dr. Dinal practices in Ethiopia. So question is, what are the things that hinder patient to use LVADs so that patients are investigated here and stop them coming to India for it if they fail to be candidates?
Oh, so you need to do a right heart catheterization. You need to tell us the pulmonary pressures. You need to tell us the pulmonary pressure, TPGs, transpulmonary gradient, PAPI, pulmonary arterial pressure, index to the body surface area, pulmonary vascular resistance less than 5 Wood units, and or reactive to pulmonary vasodilators, people that do not have intractable arrhythmias or do not have organic CVR, anything more than a moderate tricuspid regurgitation with congestive symptoms, congestive hepatopathy, and other symptoms of a right heart failure. If you do not have them, and your left heart has failed, you have some ischemia-related end organ complications, you are still a candidate for a LVAD therapy. So the only, if there is one single thing we would ask every single LVAD patient to be investigated for, rather than a series of echoes only, would probably be a right heart catheterization study. With all the pressures, with all the gradients, with the oxygen step up, with the pulmonary vascular, reactivity to pulmonary vasodilators. If you have those things to us, we are in.
Okay. Just to add to what Dr. Biswarup is saying, Dr. Dinal, as you have seen in your patient referrals also, in Jivo model, we encourage the dialogue between the Indian specialist and the local doctor through written opinion and consultations. And for even, I mean, it can be customized to that individual, that what investigations need to be done in Ethiopia to even assess whether the patient is a candidate. Dr. Asim, the pediatric cardiologist, who conducted a masterclass on timing for congenital heart surgery for pediatric patients. Like, he also mentioned that the dialogue is very important, because many times patient is too late for the relevant intervention. So whenever you face the situation, if there is somebody who really need, a lot of part happens before the travel.
Broader perspective would probably be that, oh, this is a heart failure patient. What are our venues? More often than, and I'm somebody who's very open to dialogue. I'm reachable 24/7. You can reach out to me through email, through my WhatsApp, through Telegram. More often than not, the referrals are, he's in heart failure patient. What are the options for us? And that's not the question. The question is, he's in heart failure patient who's been through everything. Now what? So now, then there is very limited. If he's been through everything, if his ejection fraction is now 10%, his right heart has completely failed. Now, if you do a right heart cath, does it really make a sense? So it should be at the beginning of the heart failure journey that we are discussing, not at the near end of it.
Okay. Okay. Any more questions, sir? Yeah, okay. There's a thank you from Dr. Dinal. Any more questions from anybody? I mean, even if you don't have questions right away, you can write it to us on your Jivo work group. Your Jivo RM will share it with Dr. Biswarup. And today's objective was to give you a general idea about heart transplant and its implications, socioeconomic implications. If you, I mean, we will assess if they want a more detailed technical medical session. We can always request Dr. Biswarup.
Absolutely. I mean, see, if you have specific numbers, if you give me specific patient dimensions, very specific patients, I am more than happy to, because I have taken up heart lung transplant as a full-time passion profession, whatever, however you want to look at it. So this is where I can be contacted. This is my email ID, and this is my phone number. So I can be reached. You can reach me through my email ID. You can reach me through Jivo. You can reach me through any platform. Because when we're discussing somebody in that heart failure journey, it is very important to discuss early and take a informed decision.
Okay. Thank you, Dr. Biswarup. So I don't think there are any more questions. So
no worries.
It's very late in India right now, almost 7 p.m.
Yeah.
So should we conclude the session, or is there something else?
Yeah, I think we can end with the thanks from this chair.
Okay.
Yeah.
Once again, I mean, thanks a lot, sir, for taking time out on a Sunday. I understand how pressure environment and how busy
only
India.
evening that we are off work, actually. Yeah,
Sunday is the only day you have for your family, and I think it's the same for our African doctor counterparts.
Absolutely.
And
the same for doctors in everywhere, barring maybe the blessed part of the West. Yeah, everywhere it's a 6.5 day week.
Although today our attendance was little lower than the normal.
No worries.
But at least the ones who came, I mean, thanks a lot to you. You took time out on a Sunday. The objective is to continue these sessions so there's a dialogue.
The objective is early referral, good referral, and intact referral. I'm not saying everybody is a bad candidate, but I'm saying let's discuss them when they're in the heart failure journey. Let's not discuss them when they're at the end of their heart failure journey. They have nothing more to be done. And then we are discussing what do we do now? Well, now there are very limited things to be done.
And I would want to go a step back, sir. The best case scenario is that if a African GP or a practitioner, they have a structured access to you, to
yes,
get in touch with you at any time, so that
yeah, we feel this guy's got heart failure. What is the way out? So now there are drugs, you know, you can delay that heart failure for a decade. You can delay coming to me for a decade. You cannot see me for a decade. You cannot think of a VAD for a decade. But you need to think at moment one. You do not need to put them on archaic medical therapies of the 1970s for a decade and then kill that soft heart into a solid, huge blown out balloon. And then we have nothing to be done. LV dimensions is north of 90 millimeters in a 27-year-old boy. This is a number from yesterday. What do I offer? I can potentially offer nothing but a transplant. And that too a very difficult one.
The idea at Jivo is to build this dialogue and connection
Absolutely.
between doctors across the borders, like the best of Indian healthcare, which Artemis and practitioners like you stand for, and our African colleagues, so that so that together you can decide what's the best for the patient. That's the objective, and that's what we're doing. So thanks everyone who attended today. Thanks a lot for taking your time out, and let's keep my request to our African doctor colleagues is that whenever you do not think like that you have to refer the patient for a heart transplant. Whenever you face that something looks complicated, just write a note. We will share with Dr. Biswarup and his team, and you will get the guidance that
responding back with a note is not something that I, as a heart failure physician, monetize as well. Let's come to the cracks in the core of it. I do not monetize my expertise. I feel it is a duty. B, it is extreme, good fortune that we can come to help people at the fringe of their lives. So I forever thought of it as a moral duty more than a monetized option. So you can always write to me. You can always have 2 free options. That's fine. I mean, I'm happy to help so long as I can go the distance and help. Thank you.
So in that sense, sir, if we will share the recording of this to those doctors who did not attend.
Absolutely.
Perhaps we can organize we will call it Jivo Connect Clinic,
no worries.
Where doctors identify those critical complex patients.
Absolutely.
They share reports in advance, and we fix a time and slot with you. The patient is in the African doctor's clinic.
Because then it is not a generalized thing. It's a very specific. Patient A, such and such, this is the option. This is the medical therapy.
That is sort of an online OPD, sir.
Yes, no worries.
Okay, we will coordinate with you, sir. Thank you. Thank you, sir.
Thank you so much. It's a pleasure.